Hi everyone, my name's Shagan. I'm a consultant in ICU and I work at Barts, and I'm here to talk to you about the hot topic in critical care ultrasound. And interestingly enough, based on all the buzz that I've heard from the European Society of Cardiology meeting that happened over the weekend, it's also a hot topic in cardiology right now. So all cardiologists are keen to learn about VExUS. So I'm here to talk to you a little bit about it. Here are my declarations of interest. The one that is on the screen that is most relevant to this presentation is that I am no longer a part of the official FUSI committee, but I'm still kind of part of the BI committee. And I was heavily involved. I'm a co-author on the FUSIC HD paper, and I was probably the first person in the UK to actually learn VExUS. And I learned VExUS from the guys who wrote the original paper. That's André Denot, William Bourbin-Soligny, and Philippe Roller. And when FUSIC HD was being written, my two contributions to the FUSIC HD questions were dynamic LVOT obstruction and VExUS. So I was involved in actually writing what the minimum data set for VExUS is in FUSIC HD. And you've probably, for people who've signed on to the online learning, I do the online learning for VExUS, so that's my voice and my presentation that you guys listen to. So hopefully lots of the stuff that I'm teaching you, if you're actually actively enrolled in FUSIC HD, should not be new to you. However, the main thing to remember is that right now I'm very biased because I've clearly had to read and learn a lot about it, which hopefully means I'll be able to give you guys some straight talk about what VExUS is and hopefully what VExUS isn't. So here's what we're going to talk about. So I'm going to talk a little bit about the physiology and the idea behind it. We'll talk a little bit about the image acquisition. We'll talk about normal and abnormal patterns. We'll talk a little bit about VExUS grading, so hopefully with an example. And then I'll go through some clinical cases and we'll talk through a little bit of the evidence. I hope that will be okay. Okay, so here is the physiology and the main thing to understand about VExUS. So has any of you guys ever seen this picture? Some of you may have, some of you may have not. Samson's nodding because he's listened to the VExUS e-learning. So this is called the vascular waterfall. And what this demonstrates is how blood flows through your body from your aorta, which is the maximum point of pulsatile flow, and flows right back into your right atrium, which should be the minimum point of pulsatile flow. And the whole idea here is that there should be a constant cascade and a constant reduction in pressure as you go down along from the arterial to the venous system to allow blood to naturally move in the right direction. That's a vascular waterfall. And that cascade and that pressure differential actually allows perfusion, particularly the capillary and venule level, and allows there to be flow and perfusion of your organs. And so what happens is if I were to raise your venous pressure, so your pressure in your venules, your small veins, your large veins, and your vena cava, your actual vascular waterfall, so the pressure differential from the arterial to your venous side gets reduced, and you actually get reduced capillary flow and reduced organ perfusion. And that is the principle behind venous congestion. So poor perfusion is not just a consequence of low arterial flow, it can also be a consequence of raised venous pressures and also a consequence of increased resistance to venous return. And that's how tamponade and obstructive shock kills you, by massively increasing the resistance to venous return, so your vascular waterfall is abolished. So this is the theory behind the vascular waterfall and the principle behind VExUS. So now some of these ideas are not new, but a lot of the real excitement and the initial data that kind of started that started some of the VExUS interest actually comes from this paper in 2016 by Ida et al. So the idea for instance, classically in right heart failure in particular, you remember from medical school that the signs that you learn for people with right heart failure is that they get peripheral edema, but they also get pulsatile hepatomegaly, and you're supposed to be able to palpate and feel for it. And this has been a recognized sign of severe tricuspid regurgitation since forever, but also when ultrasound and 2D ultrasound and Doppler ultrasound was developed in the 80s, pulsatile hepatomegaly and pulsatile portal venous flow in particular was recognized as a sign of severe tricuspid regurgitation, with the earliest paper I could find published about this was actually in the 1990s. But in 2016, these guys, and Ida et al., actually published a really interesting paper that got a lot of people thinking about this whole concept. And what they did was they actually looked at intrarenal Doppler, and they looked at renal arterial and intrarenal venous flow. And so what they looked at, so this is actually stuff, this is paper stuff exactly from the paper. So on the top right, hopefully you guys can see my mouse moving. You can see here that what they show here is at the top right, this is what normal intrarenal arterial and venous flow is. And they basically got a picture of the kidney and they showed you exactly where they sampled, which is an interlobal vessel, where you can often get, you can sample arterial and venous flow at the same time. So the arterial flow is at the top and the venous flow at the bottom. And this is not a normal pattern on the top right. The arterial flow, you get a nice systolic spike and you get loads of flow in diastole. So your renal arteries get loads of perfusion diastole, but you also get a nice continuous hum of renal venous flow. And what they found was with people with more severe heart failure, particularly congestive heart failure, this pattern changed. And as they got essentially more severe heart failure with more signs of peripheral edema, volume overload, difficult to manage, the venous pattern in particular, well, actually both patterns changed actually. So if you look at the arterial flow, the diastolic flow component of the arterial flow reduced massively in both. And also the systolic peak started to get blunted and they got smaller and sharper. But the venous flow in particular had this really weird change. So it went from this continuous pattern to this kind of lumpy, bumpy biphase, what they call the biphasic pattern. And if you go to D, they went to what we call a monophasic pattern, where they only got a spike in diastole. So they only got a single spike in diastole, with everything else kind of completely disappeared and blunted. And they looked at these patterns of intrarenal venous flow, and they correlated them with time in hospital, congestion, and mortality. And if you can see here, the lines correlate to the different subgroups. So the flat line is normal. The blue line is grade 1. The green line is grade 2, and the bottom line is grade 3, which kind of they classified it. And as you can see, as you go up in the kind of measures of congestion, you actually got worse parameters or worse outcomes in pretty much every measure that they had. So you had more hospital admissions, you were more difficult to diarise, and your mortality was much higher. So interestingly enough, at the same time, there was this group in Montreal, in the Montreal Heart Institute, led by André Deneau, with his PhD student William Biobin-Soligny, who's a renal physician. And they were doing some really, really cool and interesting work looking at cardiac surgery, looking at post-cardiac surgery patients. And they were resurrecting all this work from the 90s on portal venous pulsatility. And what they reckoned was that there was this population of cardiac patients that they come out and their right ventricles kind of get a bit funny and they really don't do so well. And they were looking at ways to kind of try and diagnose right heart failure and separate out the group, because the problem with right heart failure is most people just say, oh, the right artery's dilated, the right heart's failing. But what they were more interested in was the downstream consequences of this right heart failure, and particularly if they could demonstrate consequences on the vascular waterfall. And they pulled all of this stuff, including some of the stuff that Ida worked on, and they started looking at things like portal venous flow and intrarenal venous flow. And this is some of their early work. And what they showed was consistently, if they used pulsatile portal flow as a marker of congestion, and they showed that basically patients who had pulsatile portal flow when they came off bypass all did worse. They all stayed in ICU longer. They all had, they all got delirious. They had worse. They had acute kidney injury. So literally it was a linear correlation with the more pulsatile your portal venous flow was and your kidney injury. They published about 4, 5, 6 papers, looking at various cohorts in cardiac failure and looking at this. And between them, interesting enough, there's another guy called Philippe Roller who worked nearby in Santa Cabrina in Montreal, who was also looking at a lot of this stuff in a group of very severe chronic heart failure patients who the cardiologists had all given up on, saying that they couldn't diarise. But what he was doing is he was using IVC and portal venous flow and some of these ideas to diarise these patients, and was actually finding that if he diarised them to normal portal venous flow, he was getting a much longer time of getting them symptom free for much longer, and they had actually outperformed their initial expectations of life expectancy and morbidity based on what the cardiologist had told them. So these two guys kind of came together and sat down, had a bit of a brainstorm, and put their ideas together with some of Ida's work. So this is before I get to that. This is the stuff that's from William Biobin-Soligny's last paper. So this is portal venous flow. So this is what your normal portal vein should look like on the top left. So it should normally be a nice continuous hum. And then as you start to get this congestive phenotype, your portal vein starts to become pulsatile. And it starts to look like this. When you get severe portal pulsatility, you can actually get a reversal of portal venous flow. So they all sat down together, they put their heads together, and they came up with this concept of trying to put all of these ideas to get some idea and quantify the degree of venous congestion, so raised right-sided pressures of the vascular waterfall. And this is the origin of this paper in 2019, and this is the original VExUS paper. So in this paper, they looked at a specific cohort of post-op cardiac surgical patients with right ventricular dysfunction, and they used their score to try and quantify which of these patients and which combination of these parameters was most strongly predictive of post-op acute kidney injury in these patients, with the logic being that if they could find the right combination of these parameters, that basically was a direct correlate of systemic venous congestion, and that would correlate with RV dysfunction, morbidity, and mortality. The same stuff that we've been seeing all these years. Initially started with pulsatile portal venous flow with the radiology in the 90s, and going all the way through to EDA and this recent paper. So this is what they eventually did. So they looked at the hepatic vein, the IVC, the portal vein, and intrarenal venous Doppler, and they looked at various combinations of severity of abnormalities, and they tried to work out which combination of abnormalities was most strongly associated with their post-op measure of acute kidney injury. So this is how they graded it. So that a normal hepatic venous flow is on the top left. So a normal hepatic vein should have flow in it that looks like a CVP waveform. So you get a wave in systole called the S wave, you get a wave in diastole called the D wave, and you get a brief reversal of flow called the atrial reversal, or AR. And as you start to get increasing right-sided pressures, initially you get blunting of the S wave, so the S wave becomes smaller than the D wave. And then when you get severe abnormalities, your S wave reverses, and you get systolic. So you get systolic S wave reversal and starts to look like a sinusoidal waveform. Portal venous pulsatility goes from being continuous to being slightly pulsatile to being severely pulsatile. And intrarenal venous Doppler we've already talked about based on the EDA paper. So you have your nice continuous waveform at the bottom, then you get interruptions, so you get the biphasic waveform. Then at severe, you get kind of the monophasic bump, which is you just get a little bump in diastole. So what they found was when they classified them, they came up with a scoring system, which they called VExUS-C, that was essentially linearly correlated with your post-op AKI risk. And this VExUS-C scoring system is what we now call the VExUS score. And this is what the VExUS-C scoring system looks like. So the first thing that you assess is the inferior vena cava, and your IVC needs to be dilated by more than 2 centimeters. If it's more than 2 centimeters, that's the first part of your VExUS score, and that gives you 1 point. If your IVC is dilated, you then move on to assessing your hepatic vein, and your hepatic vein, you then assess your abnormality. For you to score a second point on your hepatic venous Doppler, it needs to be severely abnormal. Your third step is your portal vein. And again, we've talked about the portal venous waveforms. You get another point for having a severely abnormal portal vein, and you get a point for having a severely abnormal renal venous Doppler. So the way it works is you have a grade of 0 if everything's normal and your IVC is normal. You get 1 point and you get a grade 1 if your IVC is abnormal. You get 2 points if your IVC and one of the other things, hepatic, portal, or renal venous Doppler, is severely abnormal. And you get 3 points if two or more of them is abnormal. So most people that you'll see with 3 points will have a full house. I hope that makes sense so far. If anyone's got any questions at this point in time, feel free to interrupt. Otherwise, we can save questions at the end. Samson, would you mind just keeping an eye to see if anybody's got their hands raised? Just because I don't mind people interrupting me in the middle. So at this point,
No problem.
I don't know if the sound works. If the sound doesn't work, I'll just play it. But this is a video that I recorded with GE of me performing a VExUS score. So this is how you do it. Does the sound work?
No, I can't hear it.
My name's Segun.
Oh, now I can, yeah.
The Physic Haemodynamics video lecture. It's focusing on the resistance part of the curriculum, and then specifically we're going to be discussing the science of venous congestion. So thank you very much to our model here, and I am going to start by just discussing a little bit about it. The concept of venous congestion is all about the idea that fluid excess reduces perfusion across your capillary beds of your individual organs. And this can be seen starting with the IVC and translating all the way down to the hepatic veins, the portal vein, and the renal veins. The first view you really want to get when you're looking for venous congestion is the IVC. We're very familiar with scanning the IVC using a cardiac probe. So I'll start by using a cardiac probe. The easiest way to find the IVC in particular, just to pop the probe straight down in the middle of the right underneath the cephalic process, and immediately you can get a nice view of the IVC there. Now from here, from a venous congestion point of view, what you're interested in is absolute IVC size. So we can measure the IVC using calipers just beyond the intersection, or just beyond the intersection of the first hepatic vein, and this will work out a couple of centimeters behind the right atrium. If your IVC is less than 2.1 centimeters,
I'm just going to pause that for a second. I no longer measure the IVC there. I actually measure it a little bit further back. That's too close, because if you measure it at that point, it often collapses. So actually, I try to measure it a little bit further than that. So a couple of centimeters behind the junction of the, so that's usually the middle hepatic vein there. So I go a couple of centimeters behind that, and then you get a decent section of the IVC in the middle of the liver that is less, that is basically less affected by the diaphragm. So you can truly assess IVC collapsibility or distensibility or not, and you get a true component of IVC size.
It's highly unlikely that you've got venous congestion. If it's more than 2.1 centimeters, you'll probably have got venous congestion, and you need to start looking for other signs. So from here, you can move on to the next target for scanning for venous congestion, which is the hepatic vein. You can actually Doppler it from here if you'd like to. Take a deep breath in for me, mate. Then breathe out slowly and hold your breath for a moment. What you want to do is just identify this junction here. So there's the hepatic vein junction, probably the right hepatic vein. There's color, you can put some color on just to make sure you can see the flows. There you go. Put a little pulse wave signal on there. And breathe me. This isn't quite my preference using a cardiac probe, mainly because I think the limits, the Nyquist limits are too high, so you have to change the scale. So I would actually much prefer to do this and move on.
Now, for people who only have a cardiac probe, you can do everything with a cardiac probe. What you need to do is you'll need to change your scale and you change your sweep speed. And I don't know if you, hopefully you guys have all watched the videos that I did with Sam where we talk about this. It shows you kind of the correct settings to do this with any cardiac probe. So the main thing is your standard sweep speed settings on a cardiac probe, and your standard scale is too high. So you need to turn your scale down to about 20 centimeters per second, and you need to change your sweep speed down to about 25 centimeters per second, and then you'll actually get it becomes nice and slow enough to actually give you a nice waveform. The advantage of using an abdominal probe, especially if you've got something like a sonocyte. So sonocytes can be quite fiddly for this. The abdominal probe setting on a sonocyte is actually perfect and gives you a pretty perfect picture. So people, if that's all you've got, if you've got something that allows you to fiddle a bit more, then you can play around a bit more.
Rest of the venous congestion scan using a curvilinear probe. Just have it on standard abdominal settings. So we're going to start from the same point again, which is the IVC. Nice view of the IVC there, and a nice view of the hepatic vein there. Increase again. Can I get you to take a deep breath in for me, mate? Breathe out slowly. And hold your breath for a minute. Now you can actually see that the scale's right, so you can actually get decent colour flow in the hepatic vein. Breathe normally. And now here, the S and D waves here are fused, and you can see this little wave of atrial reversal. So you can actually see that this is normal, relatively normal hepatic venous flow.
There is a big caveat that I must say here. If you're doing this in an actual sick patient, I would highly advise you actually use it with a cardiac probe and you have the ECG on, because it can be very difficult to figure out what the systolic and diastolic waves are without ECG. And it's very easy to make loads and loads of mistakes. There was a shortcut for doing portal vein without an ECG, which I'll talk about later on when I get to doing portal vein. But for hepatic venous flows, and certainly for Fusic HD, if you were submitting your logbook and I was marking your logbook, I would be strongly recommending that you have an ECG on when you're showing your hepatic venous waveforms.
Here I've got a really nice signal here where you can actually see the separation of the S wave, the D wave, and the small wave of atrial reversal. But this is perfectly normal hepatic venous flow. If hepatic venous flow had signs of venous congestion, the S wave would start to decrease, the D wave would start to increase. At severe levels of venous congestion, the S wave would be completely reversed and you end up with sinusoidal hepatic venous wave. The next bit to move on to when scanning for venous congestion is the portal vein. Portal vein is relatively easy to find. You can find the portal vein from multiple windows. There's a subxiphoid window, which can be found by pointing the probe, making the probe marker point towards the patient's right shoulder, and just pointing it just underneath the xiphoid process, and just usually around here, about 3 or 4 centimeters. They call this the X-4 technique. About 3 or 4 centimeters away from the xiphisternum, find a nice view of the portal vein. Portal vein is easy to identify. It's surrounded by fat, so it gives it a nice thick appearance as opposed to hepatic vein, which isn't surrounded by fat and is thin and connects to the IVC. There's hepatic vein with the IVC. There's the portal vein. The other way of identifying the portal vein is when you put color on it. The flow is towards the transducer, so the flow in the hepatic vein, the flow in the portal vein, is red. The one exception to this is people who have got severe portal hypertension, and they may have reversal of flow in their portal vein. However, hopefully you'd have picked up some of this stuff in the history. So you can actually do portal venous Doppler from here. I personally prefer to do it from a mid-axillary approach, simply because I think you get a much greater segment of portal vein. It's much easier to see. Can I get to just pop your arms out for me like that? Okay. So the probe's going to go on here, mid-axillary view. And there you go. You've got a nice straight segment of portal vein just there. Go on. Nice continuous hepatopetal flow in the portal vein. So now we're going to put pulse wave Doppler on that, signal on that. Slow deep breath on you. Breathe out nice and slowly. Hold your breath for a second. Breathe normal. Now we have a very interesting volunteer here. He's a young, fit person. So he has actually got an element of portal venous pulsatility. This is a normal variant, and I've confirmed this with the person who wrote most of these papers, a chap called André Deneau. In the absence of every other signs of venous congestion and in a patient with no history, this is a completely normal finding. One thing you can also do just to confirm this is to scan the splenic vein, which also will transmit the same kind of processes of the same hostility of venous congestion as a portal vein, as they're both continuous to one another. Splenic vein is relatively easy to find. All you have to do is find the spleen here, and the splenic hilum is just here. Just that. I pop the color on. There you go. A splenic artery and vein all entwined. Deep breath in from you. Breathe out. Hold your breath just for a moment. So same thing here. I'm going to pop pulse wave Doppler signal. Breathe normal. So in the normal patient, what has been described is the normal flow in the hepatic, in the portal and splenic veins, when there's no congestion, is nice and linear. As you start to get more and more congested, you start to see an increase in pulsatility. A pulsatility of less than 30% is considered normal. As you start to get above 30%, this is considered significant for pulsatility, especially when considered in the light of an abnormal hepatic vein and an abnormal IVC. So here we have pulsatility that's less than 30%. I can measure the pulsatility index, but I'm not going to demonstrate that for these purposes. And
so Samson, you'll remember, I actually can't remember, does Physic HD encourage you to measure portal venous pulsatility?
Portal venous, yes, but not splenic.
That's fine, no worries. It's just that, so I rarely measure it, I just look at it. But you can actually measure it, and if you want to measure portal pulsatility, you need to measure the peak systolic bit, and you need to measure the end diastolic bit, and it's them divided. Also, so peak peak systolic flow minus end diastolic flow divided by peak systolic flow will give you a portal venous pulsatility fraction. And so more than 50% is considered significant.
in somebody with a normal IVC and normal hepatic vein signal, this is likely to be normal. If they were abnormal, they would start. The abnormalities would start from the IVC and work their way downwards. The last segment of venous congestion to consider is going to be scanning the renal artery and vein. Okay. Just lift your arm up. Just pop your arm behind your head. That's right. I'm just going to scan the left side. So I normally do this with the right kidney. The left kidney is a little bit more, is often a little bit more posterior, but it's relatively easy to find on this nice young model here. There's a spleen. I'm going to go posteriorly to the stomach, and there you are. There's the left kidney. Just going to try and get a better picture. That's a little bit better. Turn a little bit towards me. Just turn a little bit like that. Perfect. Okay. So first thing we want to do is get a nice full clear image of the organ in particular. So there's a nice image of the left kidney. We're going to pop color flow on. Now, when examining the kidneys for venous congestion, what you're looking to do is to get a Doppler signal that combines both the renal artery and renal vein. And you can get both signals at once, one above the baseline, which will be the renal artery, and one below the baseline, which will be the renal vein. You're looking for a segmental structure, so you want a vessel that's just in the outer cortex. So probably the outer, so if you divide the cortex into thirds, anything from the outer third of the from the inner third of the cortex outwards. So you probably want a signal about there. Quite difficult when people are breathing or people are ventilated, so you want to try and get them to hold their breath, or if they're a ventilated patient, you can use an inspiratory hold. If not, you can usually catch just enough of a signal in between breaths just to be able to make a decision. So breathe normally. Deep breath in for me now. Breathe out nice and slowly. Then hold your breath for a moment. Okay. Once you've got breath like this, pulse wave. Breathe normally. So this is the kind of signal that you're looking for. You want to get a nice pulse wave signal that looks like this. So you can see this is a pulsatile segment above the baseline, and that's signal coming from the renal artery. And you've got a continuous segment below the baseline, and that's the renal vein. So there's several things that happen to the signal during venous congestion. So the first thing that happens is you get reduced renal diastolic arterial flow. The diastolic segment of arterial flow is actually this section here. So this is your peak systolic flow, and this is all diastolic flow. And that reduces. So the first thing you see is visibly you can actually see it reduce.
Okay, I think that's enough of that, because I think the rest of it I've kind of talked about. Cool. Okay, hope that makes sense. Now I'm going to talk about case. Real case. So you're in a DGH, 75-year-old man with a known history of heart failure, but nobody's kind of defined it. Presents to you, and he's quite poorly with an acute kidney injury, a lactate of 10, and abdominal pain. And he's referred to you to ICU for optimization of for pre-optimization for laparotomy, as the surgeons have told him that, as the surgeons have said that they won't operate on him while in his current state, and he needs to be optimized with fluids and inotropic support before he goes to theatre. And you are a Physic HD professional, so you decide that you're going to scan him and use your newfound skills of optimizing flows, etc., to optimize his cardiac output. Because unfortunately, you haven't got a cardiac output monitor. You just have one of those random Lidco rapid things that just generates random numbers when you put it on the patient. You scan him, so this is what his heart looks like. So that's not pumping very well at all, is it? You look in the short axis, and the systolic function is equally bad. You put some color on. Looks like there's quite significant LV dilatation, and there's probably at least moderate MR secondary to the dilatation, so what we call secondary MR. It also looks like there's some tricuspid regurgitation there, and it also looks like there's terrible right ventricular function as well, and both atria are dilated. You look at his IVC, so let's bear in mind that this gentleman is actually an extremis and is hunched over the bed, breathing and using all of his accessory muscles. And look at his IVC, and that IVC is barely moving. You measure it, and it's 2.3 centimeters. You then have a look at his hepatic vein, and what you can see is pretty sinusoidal movement. So there's lots of flow backwards and there's lots of flow forwards. You have a look at his portal vein, and interestingly here, he's actually got sinusoidal waveform in his portal vein as well. So he's got flow reversal in his portal vein. So based on what we know, what would we say his VExUS score is? Type your answer in the comments. Samson, I can't see the comments, so if you could read them out for me, that'd be great. Or actually, I can log in on my phone and I can see them.
3 people have said 3.
Okay.
Grade 3.
Okay, let's just log in. Wait for a couple more people. Anybody else? Any takers?
Another grade 3.
Okay, cool.
Another grade 3. That's Gokul, Rivan, Kenny.
Okay, fantastic. Bad. Okay, time's up. Yep, hits a 3. He's got a distended IVC. He's got severe abnormality in his hepatic vein, and he's got severe abnormality in his portal vein. So I didn't actually bother doing his kidneys at that point in time because I had the answer. So the treatment for him was not a laparotomy. The treatment for him was actually inotropes and decongestion. So he needed positive inotropy to help his left ventricle pump. And then he needed he basically needed furosemide and lots of diuresis to help him to help decongest his right heart. And he actually improved quite significantly with that, and his lactate just fell like a stone. He didn't need an laparotomy at all. Right. So we've talked about all the wonderful things about VExUS. Here are some of the caveats. So the first thing is, I don't know if any of you guys have tried this. Hopefully some of you have tried. So Samson, you've tried it. How easy was VExUS when you were collecting your logbook?
Yeah, I mean, yes, definitely some of the views, especially in some of the intubated patients or bigger patients. Yeah, it can be quite hard to get especially the renal, as you've put there.
So in the expert hands, so this is William Biobin Soligny, who has basically written half his PhD on VExUS and wrote the paper. Him and André can get renal views in 75% of the patients. So you can expect to fail at VExUS at full VExUS in a quarter of your patients. This is fine because the caveat here is if you've got severe systemic congestion, you should be able to find it before, with just 2 of them, and you don't need to do all of it for everybody. We've already talked. One of the things I've left out here, but I've mentioned in the video, was the normal person with pulsatile portal venous flow. So beware of that, athletes in particular. Hopefully you're not just looking at the ultrasound, you're actually looking at the patient to recognize that this is a well person without any signs of systemic venous congestion. Cirrhosis and hepatic and veno-occlusive disease will both give you high portal pressures, and therefore they will give you portal venous pulsatility. That makes it very difficult to use. Severe tricuspid regurgitation is a very interesting one because everybody with severe tricuspid regurgitation, by definition, will have a dilated IVC and flow reversal in the hepatic vein. So they all have a VExUS score of at least 2. So, but interestingly enough, that doesn't make VExUS completely non-usable because there is a paper that shows that portal venous flow in these guys, because some of these people will have, so at their baseline, they have, they've got torrential TR and they've got flow reversal and they've got dilated IVC, but they're actually fine because you can basically diurese them enough for them to actually be relatively well, and for there to be enough forward flow for them to perfuse their organs. So there's some really cool data that was published this year on just in these patients using portal venous pulsatility as a potential guide for managing their volume status. And apparently it works quite well and works better than just using dry weight. And the last big one is, of course, abdominal compartment syndrome, because that basically just throws off everything and squishes your IVC, so therefore you can't use it. Doesn't work in ECMO as well because you've got a big pipe in the IVC draining stuff, so that doesn't work. Now is a controversy, so this is where we start talking about data. Okay, so remember, this very interesting thing about the original VExUS paper was that it was a retrospective trial. So they looked at these patients who they already knew the outcomes and they already knew their images, and they retrospectively fitted their VExUS scores to their outcomes. Now, when people try to use it prospectively, here's one of the first ones from a group in the Netherlands, and they looked prognostically at arterial and venous renal Doppler for predicting acute kidney injury. And this is 4 years ago now. They showed no correlation whatsoever. This is another study led by Rory Spiegel, who's actually one of the people involved in the original VExUS score, and they looked at venous Doppler and its ability to predict. So again, another prospective study of VExUS, and once again, it showed no correlation. So I've just told you all this stuff, but wait a minute, what's going on? There's another interesting paper, I think this came out last year, that looked at the presence of VExUS in a general ICU cohort. So remember, William Durbin, Soligny, and Deneau did theirs in a cardiac ICU cohort. They looked at general ICU cohort, and here they actually found a very low prevalence or low incidence of venous congestion, and there was no correlation between the admission of VExUS score and acute kidney injury. This is getting weirder and weirder, right? Okay, but not all is lost. Here's a paper that showed a correlation between VExUS and right atrial pressure. And here you can see it's actually pretty good. It's linearly associated with your right atrial pressure. Here's another paper. So remember we talked about VExUS and volume? So does VExUS actually correlate with your volume status? So this uses something called the mean systemic filling pressure, which is kind of a very clever mathematical way of working out your volume state, and looked at the correlation with VExUS. Now, what it shows here is that there is a correlation when you get to VExUS 3 with an elevated mean systemic pressure, but not really at VExUS 1 or 2. So again, this is interesting. What's going on? You've got all these papers out there, including myself, 4 years ago, talking about VExUS as a volume state monitor, but it's not really doing that, and it's not really correlating with acute kidney injury. Now, here's where we start getting to the real truth of the matter. So this is another really interesting prospective validation of VExUS. And here they looked at VExUS and its correlation with other markers of congestion. So they looked at right atrial pressure in particular, and they looked at mean pulmonary artery pressure and wedge pressure. And again, they showed that VExUS has a linear relationship with these signs of elevated left atrial pressure and right atrial pressure. But for me, this was one of the kickers. So you hopefully see people that you know. This is a study that came out of the UK. We published this earlier this year. This was a study that we did looking at VExUS to track volume status in patients undergoing hemodialysis. And what we did was you had these guys all coming for hemodialysis, and we all knew that they were over their dry weight, and we knew how much overloaded they were. So we basically scanned them, we echoed and VExUS them before and after. And what we found was there was no correlation whatsoever between the volume that was removed and the VExUS scores, except in one population. And that was a population with pre-existing right ventricular dysfunction. And hopefully this will be the point that I take you to. This is one of the papers that came out again this year that shows what has happened in the cardiology world. So the cardiologists are all getting really excited about VExUS, and this is because if you've got congestive cardiac failure, there is some really excellent data coming out on how useful VExUS is. In that what they've shown is that it predicts, so basically the more severe your VExUS score is, the higher your in-hospital mortality is, the worse you do again in outcomes. So very similar to EDA's work, but people are now showing it consistently in larger and larger populations. But there's a key thing here in this picture that has been missing from huge numbers of the ICU trials and some of the ICU data. And for people, those of you who go on social media or go and read VExUS opinion pieces, there's a key piece of the puzzle that's missing. And here's a key piece of the puzzle that's missing. VExUS is all about the right heart. You cannot interpret a VExUS score without looking at the right heart, because VExUS actually really correlates with right ventricular dysfunction. And that is what VExUS really is. That's what the original paper from Solini and Deneau did. And that's what VExUS will be continually correlated with. Because when you have right ventricular dysfunction and you have an elevated right atrial pressure, that is what translates into downstream venous congestion that you can assess by VExUS. Using VExUS as a volume status monitor blind, which is what people are trying to do, is a road to madness, and we should stop doing that. So again here, hopefully you guys can see what I've circled here. So remember this diagram here. What VExUS really looks at is this bit. It's the area of coupling between your venous return from your vena cava and your right atrium. And when that becomes decoupled, that is when your VExUS score starts to rise, and that's when you start to see this sonographic evidence of venous congestion. There's some interesting work coming out again from the same group, Solini, Rolla, etc., that have had the privilege of previewing, that will hopefully start talking about this interface a little bit more. You'll hopefully see that paper either later in the year or next year. But this is just a sneak preview of that. So that's what VExUS really looks at. So if you ever see anyone talking about VExUS as a volume state monitor, it is not. It has never been and will never be. We're making the same mistake as we once did with the inferior vena cava. The inferior vena cava is not a volume state monitor. What it is basically it's a measure of the complex interface between your intrathoracic pressures, your intra-abdominal pressure, and your right atrial pressure. That's what your IVC diameter tells you. And this is also very interesting. So William Solini did a presentation a couple of years ago about kind of what he was thinking about VExUS. And this is one of the things that we still don't know, and he doesn't know, and the group they're trying to work out. We don't know whether what we're actually seeing is a direct measure of venous congestion, or whether what VExUS is a risk score of congestion as a result of raised right atrial pressure. And we don't know. But hopefully over time, with more data, we'll be able to work that out. The other really interesting thing to talk about with VExUS, and this is a really cool paper if you're really interested in this stuff, is that VExUS and venous congestion and fluid responsiveness can coexist in the same patient. So one does not rule out the other. So this is all the more reason why VExUS, I refer to VExUS as thinking man's POCUS. You really have to put your hat on and think about everything. You have to think about the whole circulation. So you need to look at the left side and the right side, and do your whole Fusic HD examination in order to really understand what this means and how you can use this to manage your patient. Now, interesting enough, the final little bonus is something that we didn't include in Fusic HD, but something that you might sometimes see when you're actually looking after patients. And this is stuff that came from, again, the same group in Canada. So you've got people with right ventricular dysfunction who've got congestion. The congestion and all the flow reversal stuff actually goes all the way down to your femoral vein. So sometimes you might see this in people in whom you're putting vas caths in, or if they're sick and they've got renal failure and you're not sure what's going on. And what you can actually see, so normal common femoral venous flow is either continuous or has normal respiratory phasic variation. And then when people have signs of severe venous congestion, they actually get the sinusoidal waveform very similar to what you see in the hepatic vein. And you will notice this because I'm sure some of you guys have seen this, where people have got severe, where you've put the probe on and both the artery and the vein have been pulsatile. And you're not really sure whether you've stuck it in an artery and a vein, and you can get enough pulsatility where you actually get pulsatile flow coming back at you from your needle, and it can be quite scary. But what you're seeing is often these are people who've got severe tricuspid regurgitation from some disaster to their right heart, and that's what you're actually seeing. So understanding VExUS allows you to understand that component, and sometimes this can be your first instinct to actually go and do an echo and look at their right heart. That brings us to the end of my little whistle-stop tour of VExUS. So it's about, remember, it's about right atrial pressure and its consequences. It correlates really, really well with downstream consequences of right atrial pressure, and especially people with right ventricular dysfunction. But it's not a volume state monitor, and it doesn't always directly correlate with volume status and AKI, and that's what we're seeing in all these studies. And just remember that congestion and fluid responsiveness can exist, so it's not one or the other. And this is just a little reminder. So if you ever forget how to do the VExUS score, this infographic comes from POCUS 101, so you can download it for free. And that brings me to the end of this presentation, and I'm happy to take questions.
There's just one question on the group which was referring to your case. They've Gokul has asked, sorry if I'm pronouncing your name wrong. Was it then bowel edema secondary to venous congestion causing the pain and increased intra-abdominal pressures?
Yes.
You know, on just on one of your on one of the papers, you said about left atrial pressure correlating with VExUS. I assume that's only in the presence of left atrial pressure causing pulmonary hypertensive right heart failure.
So I suspect what we're seeing in these patients is just, so these guys have all got congestive heart failure and they've got post-capillary pulmonary hypertension. And so that's why the left atrial pressure in those cases. So people who, so VExUS is perfect. So again, and it's really interesting that it was discovered by intensivists, but really this is a perfect cardiology tool. Cardiologists should be using VExUS to diurese people and not using dry weights and random creatinine. So really interesting. And part of the reason why people got really, really interested in VExUS was you were seeing these patients with bad heart failure who their creatinine would go up, and then people would stop their diuretics, and their creatinine wasn't going up because they were too dry. Their creatinine was going up because they were congested. And so when you were using VExUS, people were actually doubling their diuretics, and these guys were actually showing a clinical improvement. So that's the population really that VExUS is absolutely perfect for: biventricular failure and biventricular congestion.
And in terms of using it as a tool to monitor treatment effect, is there evidence for anything above fluid status? Like, is there any evidence for using it for inotropes? Or
yes, so you can use it for stuff like if you've got somebody with profound RV dysfunction and you start to treat them. So you can do things like give them inhaled pulmonary vasodilators, and you watch the RV shrink and their VExUS score goes down. So again, downstream consequences of raised right atrial pressure and right ventricular dysfunction. So anything that will improve your right ventricle will improve your VExUS score. The other interesting thing to remember, and this is one of the dangers of VExUS, and think about VExUS by itself, other things that result in RV failure, so a pulmonary embolus, for instance, will actually give you a positive VExUS score. So be careful about the way you use it. You have to think about the whole heart. So do not use VExUS by itself. Do an echo first and then VExUS. That also explains why, by the way, the fact that pulmonary emboli increase your VExUS score also explains why there's papers showing that you give people furosemide and it can actually improve their right ventricular dysfunction and make their pressures go up when they have pulmonary embolus. I wouldn't try that at home though. So that's a good point. So lots of people go from the left heart to the right heart. The main thing here is that VExUS simplifies, and because a lot of people don't look at, so what we have with ultrasound and echo is because there's loads of stuff in echo on, EOV prime, blah, 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 blah. And more importantly, and also we have lung ultrasound, which simplifies all of it. We have basically direct ways to look at signs of left-sided congestion. We have chest x-rays, we have lung ultrasound. But until VExUS came out, we didn't have direct ways of looking at right-sided congestion. And this is what this is. This is basically your wedge pressure of the right, kind of your downstream consequences and your pulmonary edema of the right side. So this gives you a way and a tool to assess that.
In the HD guide or paper or whatever, they talk about like basically for valves it's like 2D and then some color and then downstream upstream effects. So if we think of the effects as the downstream effects of the right atrium and the right sided valves and the that's all great. Would you? Because what would there's some things that are missing from that, like for example, they don't tell there's nothing about looking at the pulmonary veins for looking at the left atrial pressure. And do you think that they're likely to start including that? Is that
No? And there's a reason for not including pulmonary veins is because it's really hard and it's really hard and it's very difficult to do on transthoracic. And also pulmonary veins are a bit like the IVC. They only really predict stuff at extremes. So E over E prime. So again, Ash and Marcus had a big talk about this. E over E prime was chosen because it's simple. It's not perfect by any means. If you look at the middle bits of E over E prime, it's a complete scatter plot, but it kind of semi works if your left atrial pressure is like sky high, like 30. But the other thing as well that we have access to is B lines, and B lines are actually remarkably good at telling if your left atrial pressure is raised. So in that, the feeling was that that works. So making it more complicated by putting in pulmonary veins or mitral propagation velocity, that's EDEC and BSc level 2 stuff. That's not kind of your daily intensivist stuff. And then Kenny has asked about the serial VExUS for endpoints of diuresis. I would say in selected cohorts, I would say yes. In practice, I actually don't, and that's because I work in a cardiac center. So most of my patients, when they turn up to me, are VExUS 3. So I will do it once at the beginning and then take 10 liters of fluid off them, and I will probably never do it again because I'll just look at their creatinine, which comes down, and they just get better. I will only repeat the VExUS scan if I have questions. So if I've reached a point where they don't seem to be getting better, and I think that clinically, I've dried them out as much as I possibly can, then I'll do it again. So I actually have a case of this upstairs at the moment of a woman who, before the weekend, last week, it looked like she was all overloaded and VExUS positive. And then we scanned her. So I took liters of fluid off her and I scanned her again after the weekend. And she had a slit-like IVC, that hyperdynamic LV function with a mid-cavity gradient. And then he realized that actually, oh no, we have actually achieved our endpoint. So there's something else going on. So VExUS and inspiration and expiration doesn't matter.
Just for that the femoral vein thing that you showed, was that S wave reversal that you were showing, or that wasn't the A waves, right?
So the femoral vein, so if you think about it, what you're seeing for all of these veins, so your femoral, except for the portal vein is its own separate circulation. For the hepatic vein and the intrarenal vein and the femoral vein, you're basically seeing your CVP waveform upside down, because that's what's happening. And what you're basically seeing, so with your CVP waveform, when you get severe TR and right side of failure, you get giant V waves, right? And this is what you're seeing. You're seeing giant V waves on an ultrasound. And so that looks like that. You're muted, mate.
That's very helpful. Thank you. Just one last question. You mentioned about doing the spleen. Does the spleen add anything over the portal vein, or is that just you can't see your portal vein?
Nah, to be honest, it's just if there's ever for some reason you can't find this portal vein, the spleen is probably, I mean, I haven't tried it yet. It may be more useful as an accessory window when you're doing TOE. So yes, you can do VExUS with TOE. And the report, interesting enough, the echo report that I was doing just before I started this was actually me reporting somebody I VExUS with TOE. But in TOE, sometimes it's easier to see the spleen than it is to find the portal vein. So that's probably more useful. And every now and again, there may be something like, I don't know, maybe somebody who's got tips or something like that you may not be able to assess. So the spleen is kind of an accessory window. There's also other really, really clever things that André Deneau does with splenic Doppler. But I'm just far too clever to talk about this, and basically another 2-hour talk, but we'll talk about that another time.
Awesome. Thank you, Segun. Is any other questions? Because we're now 7:02 and if nobody has any burning questions, then we'll let you all go home. Segun included, who's still at work.
Yeah, it's fine. You've all got me on WhatsApp. You can WhatsApp me with stuff. Hopefully watch the video with Sam, because Sam has done so Sam and I recorded a video that I put in the group, so make sure you watch that, because that actually talks Sam really wants to focus on the technicalities of doing VExUS with a cardiac probe and getting the image properly, image quality properly. Watch out. I mean, so if you really want to learn this properly, you really need to do it and read the original papers from André and William Biobi and Soligny. They run their own course on VExUS, and that is the best course to go to, in my opinion, if you really want to learn this properly. I run a course, so we run a course at Bart every year, usually in July. So if you're interested, and I will do my best to teach it to you properly. So if you want to learn it hands-on, then come and learn from us. Otherwise, just be careful of all the opinion pieces flying around that are all like VExUS is a volume state monitor and people talking about VExUS without looking at the right heart. Just be very, very careful. So yeah, it's all about the right heart. Please remember that.